Good day. Let me give a consolidated view on respiratory distress and acute respiratory failure. Dyspnea is a subjective feeling of difficult, labored, or uncomfortable breathing, which patients often describe as shortness of breath, breathlessness, or not getting enough air. Tachypnea is rapid breathing. Orthopnea is dyspnea in the recumbent position, which is often the result of left ventricular failure but can also be seen with diaphragmatic paralysis or chronic obstructive pulmonary disease. Paroxysmal nocturnal dyspnea is orthopnea that awakens the patient from sleep, prompting an upright position in order to resolve breathlessness. Hypopnea is dyspnea associated with only one of several recumbent positions, which can occur with unilateral diaphragmatic paralysis, with ball valve airway obstruction, or after surgical pneumonectomy. Tachypnea is the opposite of orthopnea, which is dyspnea in the upright position. It results from the loss of abdominal wall muscular tone and, in rare cases, from right to left intracardiac shunting, as occurs from a patent foramen ovale. Hyperpnea is essentially hyperventilation and is defined as minute ventilation in excess of metabolic demand. Respiratory distress is used combining patient's subjective sensation of dyspnea with signs indicating difficulty of breathing. Ventilatory or respiratory failure occurs when the lungs and ventilatory muscles cannot move enough air in and out of the alveoli to adequately oxygenate arterial blood and eliminate carbon dioxide. Dyspnea arises from the interaction of multiple pathophysiologic mechanisms. Sensory information about respiratory activity is generated by multiple afferent receptors, which is integrated in the CNS at both the subcortical and cortical levels. The current explanation for dyspnea is when imbalances exist among the inspiratory drive, efferent activity to the respiratory muscles, and feedback from afferent receptors. Dyspnea is a feature of many disorders seen in the emergency setting, so we assess for evidence of impending respiratory failure such as marked tachypnea and tachycardia, stridor, use of accessory respiratory muscles, including the sternocleidomastoids, sternoclavicular, and intercostals, inability to speak normally as a consequence of breathlessness, agitation or lethargy as a consequence of hypoxemia, depressed consciousness due to hypercapnia, and paradoxical abdominal wall movement when the abdominal wall retracts inward with inspiration, indicating diaphragmatic fatigue. We usually give oxygen in patients with these signs and are on standby for more advanced measures. For diagnosis, we ask about recent infectious and environmental exposures that may impair respiratory function. We also may experience this with drug interactions, and dyspnea is also a prominent symptom of heart failure, so it is important to differentiate it from pulmonary causes of dyspnea. An S3 gallop on physical examination or pulmonary venous congestion or interstitial edema, especially with concomitant cardiomegaly, strongly suggest heart failure as the cause of the dyspnea. So when you see jugular venous distension on examination and alveolar edema on chest x-ray, it suggests heart failure. Wheezing, dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, and leg edema are not useful in discriminating between cardiac and pulmonary causes. I usually use pulse oximetry, but it is insensitive and it doesn't really screen for disorders of gas exchange. Arterial blood gas analysis cannot evaluate the work of breathing. However, it can find the rare patient with dyspnea or tachypnea with no evidence of hypoxemia or pulmonary disease. Spirometric analysis usually requires voluntary effort from the patient, which may not be feasible when they have dyspnea. B-type natriuretic peptide, which was discussed in previous chapters, can be used for checking for heart failure, a normal BNP of less than 100 picograms per milliliter, or N-terminal pro-BNP of less than 500 picograms per milliliter excludes heart failure in low and moderate test probability patients. But when the BNP is between 100 and 500 picograms, it's very hard to use this to rule in or rule out heart failure. Common causes of dyspnea include obstructive airway disease such as asthma, COPD, decompensated heart failure or cardiogenic pulmonary edema, ischemic heart disease, including unstable angina and myocardial infarction, pneumonia, and psychogenic causes. The most immediately life-threatening causes include upper airway obstruction due to foreign bodies, angioedema or hemorrhage, tension pneumothorax, pulmonary embolism, myasthenia gravis, Guillain-Barré syndrome, botulism, and fat embolisms. So, when it comes to hypoxia and hypoxemia, these two terms are not interchangeable. Hypoxia is insufficient delivery of oxygen to the tissues, whereas hypoxemia is an abnormally low arterial oxygen tension. Hypoxemia is the most common cause of hypoxia, but as mentioned, they are not interchangeable. Relative hypoxemia is a term used when arterial oxygen tension is lower than expected for a given level of inhaled oxygen. The degree of relative hypoxemia is usually assessed by calculating the alveolar arterial oxygen partial pressure gradient. Hypoxemia results from the combination of any of these five: hypoventilation, right to left shunt, ventilation perfusion, mismatch, diffusion impairment, and low inspired oxygen. Of these, right to left shunting is failure of arterial oxygen levels to increase in response to supplemental oxygen. At least that is a hallmark of right to left shunting. The rest will increase, or rather, arterial oxygen levels will increase in response to supplemental oxygen. So when it comes to hypoventilation, hypoxemia from hypoventilation alone has an increased PaCO2 and a normal alveolar arterial oxygen gradient. For right to left shunt, it occurs when blood enters the systemic circulation without traversing the ventilated lung. There's always a small degree of right to left shunting because of the direct left atrial return of the oxygenated blood from both the coronary veins and bronchial arteries. But this may increase in a variety of conditions such as congenital cardiac malformation and acquired pulmonary disorders such as consolidation and pulmonary atelectasis. For ventilation perfusion mismatch, this may occur when there's a regional alteration of either ventilation or perfusion, and these include pulmonary emboli, pneumonia, asthma, chronic obstructive pulmonary disease, and extrinsic vascular compression. Diffusion impairment occurs when there is a problem with pulmonary gas exchange in the form of problems with diffusion across the alveolar blood barrier. For low inspired oxygen, decreased ambient oxygen pressure results in hypoxemia, especially in high altitudes. The three distinct acute compensatory mechanisms for hypoxemia include an increase in minute ventilation, pulmonary arterial vasoconstriction decreasing perfusion to hypoxic alveoli, and sympathetic tone increasing to improve oxygen delivery by increasing cardiac output, usually with an increased heart rate. Chronic compensatory mechanisms include an increased red blood cell mass and decreased tissue oxygen demands. Acute compensatory mechanisms are always activated when PaO2 reaches below 60 millimeters mercury, and compensatory mechanisms fail when it falls below 20 millimeters mercury. Signs and symptoms of hypoxemia are nonspecific. CNS manifestations include agitation, headache, somnolence, coma, and seizures. And although tachypnea and hyperventilation are often present, by the time that PaO2 is less than 20 millimeters mercury, there is central depression of respiration. Cyanosis is not a sensitive or specific indicator of hypoxemia. More on that later. So hypoxemia is defined as a PaO2 of less than 60 millimeters mercury. That is, diagnosis requires arterial blood gas analysis. Hypercapnia is exclusively caused by alveolar hypoventilation and is defined as a PaCO2 of greater than 45 millimeters mercury. So pathophysiology involves the dead space, which is the portion of the tidal volume which remains in the non-gas exchange portions of the respiratory system. This is determined by the anatomic size of the conducting airways, such as the trachea and the bronchi. So, alveolar volume is tidal volume minus dead space. And signs and symptoms of hypercapnia depend on the absolute value of PaCO2 and its rate of change. In acute elevations, you may notice increased intracranial pressure, headache, confusion, or lethargy as a result of this. In severe hypercapnia, it could produce seizures and coma. Extreme hypercapnia can result in cardiovascular collapse, but it's usually only seen with acute elevations of greater than 100 millimeters mercury. Diagnosis also requires arterial blood gas analysis because pulse oximetry assessment can be normal. Hypercapnia is treated by increasing minute ventilation, both the respiratory rate and the tidal volume as appropriate. This involves ensuring a patent airway and may require non-invasive ventilation, mechanical ventilation, the use of an antidote to reverse drug toxicity, or a respiratory stimulant such as doxapram. We do not withhold oxygen required to maintain minimum saturation levels in any chronic lung disease patient in an effort to stimulate ventilation and reduce hypercapnia. Wheezes are musical adventitious lung sounds produced by airflow through the central and distal airways with a prolonged duration of more than 80 milliseconds. They differ from rhonchi, which are dampened sinusoidal sounds of lower frequency of less than 300 Hz and a prolonged duration of more than 100 milliseconds. Crackles or rails are intermittent individual sounds typically less than 20 milliseconds in duration. Wheezing is more prominent on exhalation, in contrast to upper airway stridor, which is prominent on inspiration. Wheezes are theorized to be produced by airway flutter and vortex shedding from the central and distal airways. It is usually associated with lower airway disease, such as with asthma or other obstructive pulmonary diseases with muscle spasm or inflammation. The differential diagnosis includes upper airway, but that would be more likely to be stridor. Angioedema, either allergic, angiotensin converting enzyme inhibitor derived or idiopathic, foreign bodies, infections such as croup, epiglottitis, and tracheitis, lower airway, asthma, transient airway hyperreactivity caused by infection or irritation, bronchiolitis, COPD, foreign bodies, cardiovascular causes such as cardiogenic pulmonary edema or cardiac asthma, non-cardiogenic pulmonary edema, also known as acute respiratory distress syndrome, pulmonary emboli, and psychogenic. So, cough is a protective reflex for clearing secretions and foreign debris from the tracheobronchial tree. It is initiated by the stimulation of air tent receptors located in the larynx, trachea, and other major bronchi. Once stimulated, the cough center initiates a stereotypical cough pattern, which is a deep inspiration followed by attempted expiration against the closed glottis that suddenly opens, providing a forceful exhalation of gas secretions and foreign debris. Cutoffs for acute, subacute, and chronic cough are for acute, less than 3 weeks, subacute, 3 to 8 weeks, and chronic cough is more than 8 weeks. For acute cough, it's most often caused by upper respiratory tract infection, lower respiratory tract infection, and allergic reactions. Also, asthma, environmental irritants, transient airway hyperresponsiveness, and foreign bodies. For chronic cough, it can be caused by smoking and chronic bronchitis, upper airway cough syndrome, formerly known as postnasal discharge syndrome, reactive airways disease and asthma, GERD, angiotensin converting enzyme inhibitors, ARBs, and post-infectious, especially in pertussis. Subacute cough is usually post-infectious. Less common causes of chronic cough include heart failure, bronchiectasis, lung cancer, or other interthoracic masses, emphysema, occupational and environmental irritants, recurrent aspirations or chronic foreign bodies, psychiatric, and cystic fibrosis, interstitial lung disease. When it comes to diagnosis of cough, most cases of acute cough do not warrant ancillary tests. Chest radiograph is usually wise for patients with purulent sputum and or fever. And for subacute and chronic cough, we determine if it is post-infectious. If it is post-infectious, we assess for transient bronchial hyperresponsiveness, asthma, pertussis, upper airway cough syndrome, pneumonia, or acute exacerbation of chronic bronchitis. When it comes to hiccups, it's also known as singultus, and it's an involuntary spastic contraction of the inspiratory muscles. They don't have a specific protective purpose, and the afferent arm of the hiccup reflex consists of the phrenic and vagus nerves and the thoracic sympathetic chain. Glottis closure usually inhibits inspiration and prevents aspiration during swallowing, so inspiration normally inhibits glottic closure and maintains an open airway. The hiccup reflex disrupts the connection between these two processes so that 30 to 40 milliseconds after the onset of inspiration, glottic closure is stimulated. Hiccups usually appear to result from stimulation, inflammation, or injury to one of the nerves of the reflex arc when there is a specific cause that can be assigned. It's benign and self-limited, but it could also be persistent and intractable. For benign or self-limited or acute hiccups. It could be caused by gastric distension, alcohol intoxication, excessive smoking, abrupt changes in environmental temperature, or psychogenic. If it's chronic, it can be due to CNS structural lesions, vagal or phrenic nerve irritation, uremia or hyperglycemia, general anesthesia, thoracic, abdominal, prostate, and urinary tract surgical procedures, craniotomies, or foreign bodies in the ear touching tympanic membranes, especially hair. For this reason, the treatment of hiccups involves physical maneuvers such as removing foreign bodies from the ear, swallowing a teaspoon of sugar, sipping ice water, or drinking water quickly. The reason why these maneuvers are postulated are based on the concept that stimulating the pharynx will block the vagal portion of the reflex arc and abolish the hiccups. Drug treatment also works by inhibiting the reflex arc. Of the recommended drugs, only chlorpromazine has US FDA approval. Metoclopramide can also be used. It usually takes effect within 30 minutes, and adverse effects include extrapyramidal symptoms with both and hypotension with chlorpromazine. So other agents include haloperidol, nifedipine, valproate, baclofen, and gabapentin. Central cyanosis is cyanosis of mucous membranes and the tongue due to inadequate pulmonary oxygenation or an abnormal hemoglobin. Peripheral cyanosis is cyanosis of the fingers or extremities from vasoconstriction and diminished peripheral blood flow. So, all conditions that can cause central cyanosis also result in peripheral cyanosis. Differential diagnoses include, for central cyanosis, hypoxemia or abnormal hemoglobin. For hypoxemia, it could be due to high altitudes, which decreases the fraction of inspired oxygen, hypoventilation, ventilation perfusion mismatches, and right to left shunt in congenital heart disease, pulmonary arteriovenous fistulae, and multiple intrapulmonary shunts. For abnormal hemoglobin, it could be methemoglobinemia, sulfhemoglobinemia, or carboxyhemoglobinemia. For peripheral cyanosis, it could be due to reduced cardiac output, cold extremities, maldistribution of blood flow with distributive forms of shock, which include neurogenic shock, septic shock, and arterial or venous obstruction. Cyanosis is usually visible when the oxygenated hemoglobin exceeds 5 grams per deciliter, but could also be noticed by more acute individuals at 1.5 grams per deciliter of the oxygenated hemoglobin. The tongue and buccal mucosa are thought to be sensitive sites for observing central cyanosis. Pseudocyanosis is a bluish or slate gray skin discoloration due to drugs like chlorpromazine, minocycline, amiodarone, nicorandil, or heavy metals such as gold or silver. In pseudocyanosis, the lips and mucous membranes are normal in color, and the abnormal skin discoloration does not blanch with pressure, with discoloration being more intense in sun-exposed areas. Factors that influence the physical appearance of cyanosis include physiologic factors such as oxygen blood content, degree of oxygen extraction, and oxyhemoglobin dissociation curve, anatomic factors such as the status of microcirculation, skin pigmentation, and skin thickness, and physical factors such as quality or intensity of life in the examination area and the skill of the physician. With carboxyhemoglobinemia, pulse oximetry often reads carboxyhemoglobin as oxyhemoglobin, which reports a higher percentage for oxygen saturation. Arterial blood gas analysis using co-oximetry is needed in assessing a patient with suspected cyanosis. Pleural effusions result from fluid accumulating in the potential space between the visceral and parietal pleura. Although pleural effusions can result from many causes, most common causes are heart failure, pneumonia, and cancer. A continuous amount of fluid is secreted from the parietal pleura into the pleural space where it is absorbed by the visceral pleural microcirculation, averaging about 8 liters a day in an adult. This fluid reduces friction between pleural layers and allows for smooth lung expansion and contraction with respiration. Any process that increases fluid production or interferes with fluid absorption will result in pleural effusion through accumulation of fluid in the pleural space. A pleural effusion may be clinically silent or come to detection from either symptoms of an underlying disease, an increase in volume of the effusion with the production of dyspnea, or the development of inflammation and associated pain with respiration. So the differential diagnosis of pleural effusion includes transudates, heart failure being more common, and less common are cirrhosis with ascites, peritoneal dialysis, and nephrotic syndrome. For exudates, you usually have cancer, primary or metastatic, bacterial pneumonia with pneumonic effusion, and pulmonary embolism. Less commonly, exudates can be caused by viral, fungal, mycobacterial, or parasitic infection, SLE, rheumatoid arthritis, uremia, pancreatitis, post-cardiac surgery or radiotherapy, or immunodome. Either transudates or exudates may occur in diuretic therapy, in which the protein concentration increases, so it may fall under exudative territory even if it was originally transudative, or in pulmonary embolism. So 150 to 200 milliliters of pleural fluid in the hemithorax is required to be detectable on upright chest radiography. A significant pleural effusion is large enough to produce a pleural fluid strip of greater than 10 millimeters wide on lateral decubitus radiographic views or by ultrasonography. So the most common criteria to differentiate transudates from exudates is the light criteria, which means that one or more of the following are present: pleural fluid over serum protein ratio of greater than 0.5, or pleural fluid serum LDH ratio greater than 0.6, or pleural fluid LDH greater than 2/3 of the upper limit for serum LDH. Additional tests that can be performed on exudative effusions include gram stain and culture cell count, and neutrophilic predominance may occur in parapneumonic, pulmonary embolism, and pancreatitis. Lymphocytes may predominate in cancer, tuberculosis, and post-cardiac surgery. Glucose may be low in parapneumonic, malignant tuberculosis, and rheumatoid arthritis causes of pleural effusions. Cytology for malignancy has a higher yield with adenocarcinoma and much lower for squamous cell lymphoma or mesothelioma. For pleural fluid pH, the normal pleural fluid pH is around 76.4, or rather 7.64. So in parapneumonic effusions, a pleural fluid pH of less than 7.10 predicts development of empyema or persistence and indicates the need for a thoracostomy tube drainage. Pleural fluid amylase is elevated in pleural effusions due to pancreatitis or esophageal rupture, and tuberculosis pleural fluid markers may also be requested if tuberculosis is suspected. Diuretic therapy typically resolves more than 75% of effusions due to heart failure within 2 to 3 days. Patients with pleural empyema, which is gross pus or organisms on gram stain, require drainage with large bore thoracostomy tubes. And that's it.